Please, Rosanne, thank you for coming. It's a pleasure for us.
Thank you. It's truly an honor to be here. Thank you so much for coming despite the heavy, heavy rain. First of all, I would like to apologize that my Portuguese is not very good. What you may be hearing tonight is more of a version of Portinglês. So I apologize. I will try my very best here. If I'm speaking too fast, please just raise your hand and tell me to parar. Devagar, por favor. Okay? I think this is a beautiful environment that you have to bring in technology and how we can combine it with surgery and techniques. We are definitely in surgery as gynecologists extremely dependent and reliant on our efficient and excellent sonografia, imaging, so that we can perform and provide the patient with the best approach for their surgery. What I would like to do with you for the next few minutes, I know it's late, everybody's hungry, is to just give you a little bit of a flavor of the current state of vaginal hysterectomies in the United States, talk about how we can modernize the procedure so that more procedures for benign hysterectomies can be done vaginally. Give me an idea of how many of you do vaginal hysterectomies. Aqui, é bom. É laparoscopia? Very nice. E robotics? É bom. Oh, that's wonderful. That's terrific. So what happened in the United States in April of 2015? Este año. United Healthcare, which is the largest health carrier, insurance carrier in the country, issued a statement that every hysterectomia that is done not vaginally, con robotic, con laparoscopia, con laparotomia, will require extra permissões, extra permission, right? Also, more recently, the reimbursement, what the insurance will pay the hospitals for laparoscopic hysterectomy and robotic hysterectomy will go down by 23%, not for vaginal hysterectomy. So currently, surgeons in the United States are more interested now in the vaginal approach. The problem with the vaginal approach is that when everybody thinks of cirurgia de vaginal, like it's been in frozen animation where nothing has changed in the last 30 to 50 years. Is that true? I'd like to present to you different ways of how we can do the procedure. When one would go into a laparoscopic procedure, you're looking at a movie, right? Everybody can see. In vaginal, you have a tiny opening, everybody's looking in, your assistants are in pain with torture because their backs are hurting and they're having to assist you with their procedures. I'd like to show you different techniques of how this can be done. How can we really increase the rate of vaginal hysterectomies is if we can think of a new selection criteria for the procedure de vaginais, and also how we can think of what things we can bring into the procedure to overcome many of the challenges of the vaginal approach. We know that the vaginal procedure is the best approach for the patient, right? We've got good Cochrane review data to show that it provides the least amount of complications, better recovery for the patient. It's also the most cost-efficient, cost-effective. It's the least expensive of all the procedures. Unfortunately, in the United States, less and less procedures for hysterectomies are being done vaginally. It's now, new data is showing that it's almost 15%, 15% from 22%, right? It's going down even more. In the United States, what is real is that less than 5% of gynecologistas are doing more than 10 surgeries vaginally cada año. What has robotics done to hysterectomies? What robotics has done nicely is that it has decreased the number of abdominal procedures. Con laparotomia, for the first time in US history, it has gone down to less than 50%, that of 40%. Laparoscopia has gone up to 30%. Robotica up to 10%, and vaginal surgeries going down and down. What is this telling us? It's telling us that the gynecologistas in Estados Unidos are preferring not to do the procedure vaginally. Why? It's difficult to do. It's difficult to learn. How can we change that? It's unfortunate, right? Because every procedure outside of vaginal procedures costs more. This is done at the Brigham and Women's at Harvard. Every abdominal procedure costs $12,000 more than a vaginal procedure per case, por caso. Every laparoscopia costs $7,000 more than the vaginal procedure. And robotica, $18,000 more por caso for hysterectomia. So what we have currently is really a national healthcare crisis. Look at how many of these procedures are now being done by our residentes. By the time they finish 4 years of obstetrics and gynecology training, they're doing 19 cases. I can tell you right now, with my experience, I just was at Columbia University in Nova York. Most residency programs are ending with less than 10 cases per year. What we have really is a national healthcare crisis. It's a healthcare crisis because our residentes are not knowing how to do the procedure vaginally. Our surgeons are not doing the procedure vaginally. It's costing more to do this with other procedures. And so it's creating a huge burden on the current healthcare situation. So how can we change this? I'd like to define a new selection criteria. It's important to think about vaginal hysterectomy as not just for the small prolapsing uterus, but you can do the procedure even for the large útero grandes, and for patients who have never had a vaginal delivery or have had previous cesarean sections. How can we do that? We need to bring in tecnologia and new techniques so that we can increase the rate of success for these procedures. So this is what ACOG published in 2009, right, as contraindications for the vaginal route. The fact that the uterus is large when they've had previous surgeries, if they've never had any vaginal deliveries, if the uterus is not prolapsing, if the uterus is greater than 12 weeks in size, we have good studies to show that these can be done vaginally. These, to me, are not contraindications, but really excuses to why the procedure cannot be done vaginally. ¿Cómo se dice excuse? Disculpas. So they really are excuses. So to me, the exclusion criteria for the vaginal procedure is just two. When the patient has non-cyclic pain, acyclic pain outside of their periods, if they've never been evaluated before for endometriosis, these are patients that should be approached con laparoscopia and, if you prefer, con robotica, right? Because you cannot remove deep endometriosis with vaginal procedures. Second, if there is a high index of suspicion for cancer, whether it's endometrial cancer, whether it's a suspicious adnexal mass for ovarian cancer, or if with good imaging, there's a high suspicion for leiomyosarcoma, that should not be morcellated vaginally. Okay, thank you. So I just wanted to mention that this is a very nice editorial comment from Dr. Ingrid Nygaard, right? This came out from the Gray Journal, saying that the same principles that you use not to morcellate laparoscopically or robotically should be the same principles that you use the vaginal. Just because you're morcellating without the use of a power morcellator does not mean that you cannot do the does not mean that you can do the procedure vaginally. Is that clear? Claro? So here we are. I just wanted to share, I know this protocol is old, right? This is a protocol that we adopted from the Japanese group in 2002, where they used MRI with gadolinium, and they looked at the enhancement of the contrast at 60 seconds. In addition to that, we also used the LDH, lactose dehydrogenase. ¿Cómo se dice? DLA. Diagay. That. So it's the total LDH level con isoenzyme tipo 3. If all three are abnormal, right? If all three are abnormal, that to us is a high suspicion of index con leiomyosarcoma. So following that protocol, we looked at our data for the last 13 years in Clinica Mayo. I was at the Mayo Clinic for 12 years, where we had 4 robotic surgeons. All of us did vaginal surgeries, and all of us did laparoscopic surgeries. This, we had ended up with 2,011 patients. These are for patients who had contraindications for vaginal hysterectomy. So these are the large uteri. These are the patients who've never had other deliveries before, and we performed these procedures vaginally. The largest uterus that we took out was 2,418 grams. Okay, that was the largest utero that we took out, and our conversion rate, meaning the number of times that we were not able to finish the procedure vaginally, was less than 1%. And in over 2,000 patients, we had zero caso de leiomyosarcoma following that protocol from 2002, using the imaging and using the LDH levels. Okay? So how do we increase you who teach, you who do the procedure? What should we think about when we do the vaginal approach? We need to take the perspective of the teacher and the learner to provide us with better techniques. Vaginal procedure does no longer need to provide us with pain, right? So what I would like to propose is to bring in what we have learned from laparoscopia and robotica into the vaginal approach, while maintaining patient safety and also maintaining cost. How can we do that, right? We've learned from laparoscopia and robotica that exposure is much better with laparoscopy and robotics, that visualization, because they have excellent illumination, ergonomics is much more comfortable to do the procedures outside of vaginal procedures. How can we improve upon the ease of performance of the procedure? And how can we bring in simulation into the vaginal approach, which is done beautifully with laparoscopia and robotica, because you have dry labs, because you can use the porcine models that you cannot with a vaginal approach. So let's think about these things. First, to overcome the challenges, right? For me, it's important to put the patient's feet outside of my face. That's why I like to use the candy canes. It provides me and my assistants with more room. That's my preference. I also sit on a chair. I bring the chair much higher. I bring the whole table much higher so that it is at the level of my assistants. Okay? What else did I bring in to the vaginal approach? That of the use of an overhead projection, como laparoscopia. In any modern day operating room, there's a camera that comes with your overhead boom. You bring it into the field, you project it to an external monitor, then everybody can see. Your instrumentadora, your assistants, your anesthesia, todas pessoas in the operating room can watch and see what you're doing. They don't all have to just be thinking, what is it that you're doing? Nobody knows. Think of a situation when you run into bleeding. With anesthesia, knowing what's happening, they're able to prepare and make the procedure much safer for you. What else did we do for the vaginal approach? I brought in the Google Glass. You all know about the Google Glass technology, right? Where the chirurgien can wear the Google Glass, and this is the projection that we were able to get externally, simultaneously, while the procedure is going on. What else have I used for the vaginal approach? So, this is the Karl Storz VTOM. It's a 90-degree camera, right, that is attached to the operating table. Let me show you what we have done here. And this is for a demonstration that I did early this year. This is the VTOM that we attach to the operating table. To the side, it sits right in front of me. It illuminates, so brings in the light. It also records and projects the image immediatamente, to an external monitor so that everybody can see. These are the different live demonstrations that I have done, and I provide them to you on the web, right? Last year at AAGL in Vancouver, there was the session called Stainless Steel Surgeons, como Master Chefs, right? Where the 3 surgeons were up on the podium, and then I did the vaginal procedure. Someone else, Dr. Ted Lee, did the laparoscopia, and Dr. Mike Pitter did the robotica, con cadavers, for 30 minutes. It's competição. And everybody could see there were 2,000 pessoas in the audience, and everybody could see the procedure vaginally because of the VTOM. And let me just share with you, this is the kind of imaging that we were getting with the VTOM. What does that do? In actual surgery, my assistants are not having to look in. Instead, como laparoscopia, everybody looks up at the monitor. They can see the anatomia. They can see the next steps. They can help me better in doing the next part of the procedure. So to me, this is a game changer. Just bringing in better visualization, better illumination has changed the field of vaginal surgery, and it does not need to be expensive. It's not difficult. It's just a concept that we can bring into the laparoscopic or the vaginal approach. So let's talk about just the different challenges to the vaginal approach so that you can come into the procedure as prepared as you can be, right? What's the most difficult parts of doing the procedure vaginally? Exposure is difficult. Achieving hemostasis is difficult. Entry into the cul-de-sac anterior is difficult, muito difícil. And the large uterus, how do you take that out vaginally? How do you avoid bladder and ureteral injuries? And then, when you have to remove the tubos y ovarios, how do you do that vaginally? So let's talk about these things. Another game changer for me. Por 15 años, I've been using this book Walter. It's a vaginal retractor self-retaining system. How many of you use book Walters para laparotomias? What do you have for retractors here, the abdominal? What do you use? Huh? Goce. Para abdominal. See, it's a self-retracting system. In the United States, we use the book Walter para abdominal. Dr. Magrina, my teacher, modified the book Walter to use it vaginally. The same thing, it's self-retaining, and so my assistants no longer have to hold the retractors. Muito simples. When we've gone on our banderas proyectos de bandera científica con USP, the medicos, the students de USP, I brought the Magrina book Walter, which made it much easier for us to do 5 cirurgias de vaginal cada dia por dia, right? Because then they're not tired, and I'm not tired as well. We talk about making a larger incision around the cervix, which I think is key in removing the large uterus. The other thing that can be brought in is the simple Alexis wound retractor. How many of you have used the wound retractor para laparotomía or para laparoscopia when you take out your fibroids? Do you have this, the wound retractor? Alexis, tem or no? Tem, right? So it can be used vaginally também. So after I take out my ligaments, I would put in my retractor and it brings the vaginal walls up away from where I need to work to avoid injuries. I use light in if I need to. Now with the VTOM, I don't need to bring in a separate light to shine in because I can have that with the camera, 90-degree camera. I've also modified our Devers at the Mayo Clinic. It's now available so that I can go after pedicles that I lose vaginally. This is a simple technique that we don't often think about. It's a relaxing vaginal incision, como episiotomy, but not as big or deep as a... Do you do this for vaginal procedures? Sometimes, oh, que bom. It doesn't need to be as deep as a Chouchard. You know about the Chouchard incision. This is just very superficial, and I just want to share this with you. This is one of the procedures, demonstration, that we did for the cadaver, with the cadaver, and it's a tiny opening, right? So just with a simple, relaxing incision, con monopolar cautery, what do you call this? Bovie cautery. Bovie cautery. Just a simple incision, 2 to 3 millimeters deep, no more than 2 centimeters, right? I was able to gain about 2 centimeters wide of an incision, and then I can put all of my retractors into the vagina. É muito fácil. Okay? Just remember to close it in the end, right? Don't forget to close it. And patients tolerate it. It's not painful. The other thing to think about with entering into the anterior cul-de-sac is to delay entering into the cul-de-sac until later, when the uterus has come down into your view. So it took me 6 years to learn that, right? But it certainly is a very good technique, one that can be done very easily. How about achieving hemostasis during vaginal surgery? We have been using vessel sealing devices. Do you know vessel sealing devices, right? It's an advanced bipolar, como LigaSure or N-Seal or Ultras, which is another device that is present. We have multiple randomized controlled trials to show that these devices are helpful in a vaginal procedure. But in our hands at the Mayo Clinic, what we were able to see is not that it made us faster, it is not that it decreased the blood loss, but it helped us be more successful when the uterus is large. When the patient has had previous cesarean sections, the use of the vessel sealing device allowed us to go up more easily than with the use of traditional clamping and tying technique. And I'll show you that video here. So again, our studies here showed that traditional suturing with the clamp, cut, and tying caused us to have a higher rate of conversion compared to the use of vessel sealing devices. So these are the different devices that are available. Here's the knife that we modified. A knife for morcellation. Sometimes for a large uterus, morcellation takes over an hour with the use of over 10 different scalpel blades, right? So to me, this is a knife that has been very helpful. Let's just quickly, are you tired? Would you be willing to just go through this video with me? Okay. So this is a patient who is 44 and has previously had 2 cesarean sections, right? So we're using the Magrina Bookwalter. You can see that the vagina is tight. It's not very large. The cervix is large. She's had 2 previous cesarean sections. She's never had a vaginal delivery. But with traction, you see how nicely that cervix comes down. right? So now we make an elliptical incision around the cervix. We just go all the way around. I now want to dissect that vaginal mucosa off of the cervix. I take out the posterior blade. I deflect the uterus down. I lift anteriorly, and this is the key. Where do you make the cut? If I cut right there, I'd be digging into the cervix. If I cut up too high, I would go straight towards the bladder. So you want to go into that space where you dissect the vaginal mucosa into the utero-vesical space, right? And then we stop. We've not entered anteriorly yet. Now we enter posteriorly first with just one big bite with your bisturi, and now we're using the vessel sealing device. This is the N-Seal Super Jaw by Ethicon, okay? So we're using the vessel sealing device. We'll go after the uterosacral ligament. And the same technique, how many of you use ligature or N-Seal? Yes, con laparoscopia, see? Vaginal, hey, bon. That's wonderful. That's wonderful. I'm very happy to see that. So for the uterosacral ligaments, for laparoscopia and vaginal, it's the same technique. Mounting tension on the pedicle, right? So you gently bring your cervix down with your vessel sealing device. You push against the pedicle in order to avoid bleeding. So now we're going anteriorly. This patient has had 2 previous cesarean sections. I know she will have muitas adherencias, right? So we're going to go in very slowly. I will go right here. This to me looks like bladder because it's red, muita vermelha, right? So I will cut below it. I will go very slowly. I will take my time. I will use a Kelly forceps to bring my tissue down. I will try to go in laterally, como laparoscopia, como laparotomia. Their thickest adhesions will be central. So you want to go laterally to go away from where your adhesions are. You can see where the adherencias are, right there. I'm going below. I know I'm not digging into the uterus because it will feel hard against my scissors. I know I'm not cutting into bladder. Why? Bladder tissue will be soft and it will bleed like stink. It will bleed a lot, right? So we're not coming upon much bleeding here. This is just the thick scarring. And once we're in, I confirm with my fingers that I'm in indeed, and I put my deaver in. At this point, my heart rate goes down, my blood pressure goes down. I'm ready to go home, right? The procedure is almost done. We're on home run now. We're on third base. So you can see, just like with laparoscopia, I have skeletonized the uterine arteries. I stay lateral to the cervix, parallel to the cervix, not perpendicular. Why? This is a vessel sealing device. You will have lateral thermal spread to the clamp, right? So you want to stay near your cervix so that you don't injure the bladder and you don't injure the ureter. I also do not lean against the vagina. I don't lean against the vulva. I don't lean against the metal rods because it gets very hot. It gets very hot. And so I bring in here a suction so that it dissipates the heat. It removes the smoke right away and it does not get hot. Okay? It's very important to know your anatomia when you're doing these procedures so that even though your space is small, it's important for you to know and be always aware of where the ureters are and where the vagina is, right? There it is. There's your uterine arteries right there, inserting into the lower uterine segment. I stay parallel because this is where I know the closest part is for the ureter will be very close to my uterine arteries. Once I have isolated uterine arteries, I'm ready to morcellate. Manual, with a knife, right here. I would divide my cervix. Do you all do the same technique with morcellation? See? You divide, the cervix, and then with large tenaculo, I would go ahead and do a series of coring and wedging technique. This is the same technique that you use when the uterus is 8 weeks, 12 weeks, 16 weeks, 28 weeks, iguais. And I know that I have secured the vascular supply because it's not bleeding. Morcellation should not be bloody. If it's bloody con muito sangrado, right? Then I know I have not gotten my uterine arteries yet. I will then keep going up with my vessel sealing device and go up laterally to secure my bleeding. How do I know that I'm near the fundus? How do I know I'm near the fundus? I'll get a little bit of bleeding, a little bit of oozing because I'm close to the utero-ovarian vessel, right? So now I'm looking. I would go ahead and secure my utero-ovarian pedicle right here. And I would put my clamp.
Why don't you use the same device in this area?
Yeah, come see. Yes, absolutely. Here I am. I'm securing the pedicle. I'm bringing it closer to me. It's a larger uterus, right? It's a larger uterus, so this takes away the tension. That clamp brings the pedicle to me, takes away the tension. I use the vessel sealing device to make it much more skeletonized so that my pedicle is secure. I can use the vessel sealing device here again if I wanted to, or now. And then I do the same procedure on the other side, and I remove the uterus. Okay? Claro? Let's go through. How many of you are offering your patients prophylactic salpingectomy with the hysterectomia? Prophylactic. Oh, muito bom. So, when the patient asks you, I want to remove my tubes vaginally, let me show you some things that can be done because it can be tricky. It can be challenging. All right? So, in contrast to the traditional technique, right, of removing the tubes and the ovaries, the vaginal, this is the traditional technique of putting a large clamp onto the meso-ovarian and mesosalpinx. It's a problem, many problems and limitações with this technique. Why? Because you leave behind a portion of the tube. What else? My clamp, the pedicle on my clamp is big. The most important part of my pedicle is up at the top where it could retract from your clamp and cause bleeding. Third problem, your clamp is up against the pelvic sidewall and you're near the ureter, and that can be a problem. Okay? So let's show you a different technique. This is what we call the round ligament technique, and we just published this in the Jamie with the video. So if you want to refer to it, we offer you the round ligament technique, como la parotomía, como la paroscopía, where you would skeletonize your pedicle. You identify your round ligament, you transect the round ligament, and then it brings your pedicle down towards you. Your entire tubo is removed, and your clamp, what's left in the clamp is just the ovarian vessel, which is the most important part of your pedicle, right? So now let's watch the video. So same thing with the mesosalpinx, salpingectomy, right? Where you create a window in your mesosalpinx, I transect the round ligament, and then I would replace my clamp, and I would follow the tube and remove the entire tube. All portion of the tube leaving behind the ovary. Let's show you this video right here. Okay. So we've finished. We're almost finished here. Give me 5 more minutes, okay? So here we are. We've finished the Histerectomia de vaginal. We're on the patient's right side. We identified the round ligament right here. How do I know it's the round ligament? I follow the tube to its proximal portion. With the Bovie cautery, I would go ahead and transect the round ligament slowly. Bovie, uncut, monopolar, just up to the mesosalpinx, not beyond the mesosalpinx. So this should not be bloody, okay? Now watch the round ligament go up. Your specimen comes down to you, right? With a fine Kelly or hemostat, I like to use the shell cross. I create a window in the mesosalpinx, right there. I replace my clamp in front of enfrente de ovário, right? I would make another cut right here. So now my entire tube, the proximal portion of my tube is with me, and I can then place a clamp or my vessel sealing device, which is what I already have open, to bring me to the most distal portion. The most important part of the tube that you need to remove is the fimbria, right? But when the fimbria is high, sometimes it's difficult to remove. So think about using this technique to get you to the top, to remove the entire tube. In total, I have my long vaginal pack protecting the bowel so that I do not injure the bowel with this technique, right? Because it gets very, very hot in there. You can see my long vaginal pack, compresa, right here inside. So I just want to show you this and show you that I've removed the entire tube completely. Okay? One more video, por favor. Let's remove the tubes and the ovaries. Same technical. Okay? Patient's right side. Here's the ovary and the tube. I've placed it on a long Alice clamp. Sorry. Ay, ay, ay. It's frozen. Skip. Yeah, thank you. So we followed it all the way to the back. Otra vez. Here's your tubo all the way to the front. We bring gentle retraction. Con Bovie. I know that's the round ligament. Uncut, gentle traction. That releases your round ligament from your pedicle. It brings your specimen down towards you. I would stop right here. You can see that vessel right behind it, right there. Okay? Now I place my ovarian clamp completely behind the ovary and way past my pedicle so that my pedicle is safe and secure within this clamp. You see how we have modified this instrumento con bayonet, porque the vagina is long and your pedicle is deep. When you have a straight clamp, it's hard to get to the top. And so with a little bit of articulation, it allows us to get to the back, right? So now we can remove the entire tube and ovary. No part of the ovary is left behind. No part of the tube is left behind. We will go ahead and cut this. You cannot see in this video how high that pedicle is. My fingers are not very long, right? So it's difficult to get to the top. So this is an instrument that we have from laparoscopy. It's an endo loop, right? My pedicle is skeletonized. I go ahead and bring it to the back. It's a rotor knot. And I would go ahead and secure that knot past my pedicle. Aquí. Just secure it. How many of you have done this? Have you used it with the endo loop to tie the pedicle? No? Não precisa. No? You have longer fingers than I do. So you see how that pedicle went up towards the top of the pelvic brim. And I'm just checking to make sure it's secure, right? So this is my passion in life. It's to increase the rate of vaginal hysterectomy for everybody. And I think there are many ways in which we can do this. First is to think of a new patient selection criteria. 2, to bring in new innovation, new techniques, new technologies for the procedure. And I'm going to share this with you. This came out, I did this for AAGL and ACOG, American College of OBGYN, and also SGS in July. It's, you can get CME or credits for doing this. And Kong, Barbara Levy, and John Gebhardt, we came up with the videos to talk about anatomy, to talk about the essentials of vaginal hysterectomy. We talked about how the procedure can be done, anatomy, vaginal managing complications, and you can click on each one with the video for your students, if you will. Thank you so much for your attention.
Thank you so much for the brilliant presentation, Dr. Rosanne. Alguma pergunta? Alguém gostaria de fazer perguntas? Oi, Sérgio? Perguntas? Lá atrás uma pergunta.
Professor, how many surgeons can you teach every year? We have many problems down here because at some point in our medical career, we have to choose a side. If you go laparoscopic, if you go abdominal, or if you go vaginal. How many can you teach every year?
How many can I teach every year?
Or train, actually.
Yes, it depends on how many times you are in the operating room. So at the Mayo Clinic, I was in the operating room every other day. Every other day. In a month, I could do up to 20 to 25 cirurgias de vaginal. At Columbia, I would have 2 students, and we would play musical chairs, right? One would sit down first to enter posteriorly, and then the next one sits down first to do the vessels, then another one sits down to enter anteriorly, and then another does the morcellation. I think that if your student stays with you for 6 weeks, 6 semanas, and in surgery every other day, they can finish the 6 weeks with confidência, com segurança. Right?